Assalamualaikum, my name is RADIOTHERAPY and today I will discuss about muscle invasive bladder carcinoma. So today's objective is discuss about epidemiology, etiology, staging and classification, clinical findings, evaluation, diagnostic evaluation, prognostic markers, management and follow-up. Epidemiology. Bladder cancer is the seventh most commonly diagnosed cancer in the male and second most common cancer of the genital tract. If we combine female gender into it, the ranking goes to 11th most common cancer in the world. The worldwide age standardized incidence rate per 100,000 person per year is 9 for men and 2.2 for women. The average age at diagnosis is 65 years. At the time of diagnosis, approximately 75% of bladder cancer are localized in the bladder and 25% have spread to the renal lymph nodes or distant sites. Etiology, cigarette smoking accounts for 65% of cases in men and 20-30% in women. Occupational exposure accounts for 15-35 cases in men and 1 to 6 in women. This includes rubber factory and petroleum industries, etc. Radiotherapy is the theory in which radiotherapy is given into gynecological cancers or radiotherapy in prostate. If it is given in the external beam exposure, so it is accounted for radiotherapy. It increases the chances of bladder cancer. Surgical trauma is a induced by infection, instrumentation, and calculi increases the risk of malignancy. Genetic factors, P53 tumors are present in mutation. Deletion of chromosome 11 is a prognostic marker in the muscle invasive bladder carcinoma, and same scores to deletion of chromosome 70p. If these two are found, it is most likely for muscle invasive type of bladder carcinoma. And last, the mutation of fibroblast growth factor receptor 3. Staging classification, this was discussed previously by Dr. Rapid, so I'll just quickly go quickly over it, and I'll focus on from T2 to T4 mode. Basically, there's PX where primary tumor cannot be assessed, then there's DMOD when no evidence of primary tumor. DA is non-invasive tabular carcinoma, DI is carcinoma in situ. These are the ones which are non-invasive. From T2 to T4 are the invasive ones. Tumor invades muscle into 2A, the tumor invades the superficial muscle, the inner half, and in T3, the tumor invades deep muscles, the outer half. In T3, tumor invades the perivesical tissue. T3A is microscopic and 3D is microscopic. X or residual mass. In T4, the tumor invades any of the following surrounding structures like prostate, stoma, ventricles, uterus, vagina, pelvic wall, and abdominal wall. In T4A, the tumor invades the prostate, stoma, somatic vessel, uterus, or vagina. In T4B, tumor invades pelvic wall or abdominal wall. Then regional lymph nodes, the N classification, NX is regional lymph node cannot be assessed, and nor is no regional lymph node metastasis. N1 is metastasis in a single lymph node in a true pelvis, in multiple true pelvis. And N2 is metastasis in a multiple region lymph node in the true pelvis with a cytogastric obturator, internal iliac, or recessor. N3 is basically metastasis in a common iliac lymph node. N denotes of distant metastasis, and M0 is low distant metastasis, and M1A is non-regional lymph node, and M1B is other distant metastasis. In this figure, you can see the cut section of the bladder. From TIS to T1 are the non-invasive, which lies in grade 1 to thing is that you can say see the from 2 T to 8 muscle starts invading to the uterus to laminar propria and muscle propria is the upper here, over here. And then into B, it further invades, and into C, it starts entering the perivagal space and 4, and then adjusting structures. Like over here, and T4, it starts invading the prostate, uterus, and invasion to pelvic wall and abdominal wall. Clinical finding and evaluation. Symptoms are painless hematuria is the presenting symptoms 85 to 90% of the patients with bladder carcinoma. Other clinical signs include urgency, dysuria, and increased frequency. Symptoms of advanced disease includes bone pain from bone metastasis or flank pain from retroperitoneal metastasis for uterine obstruction. Diagnostic evaluation. We start with physical examination. Physical examination should include rectal, vaginal, bimanual palpation. A palpable pelvic mass can be found in patients with locally advanced tumor. Hepatomegaly or supracazular lymphadenopathy are signs of metastatic disease. In imaging, basically the bladder cancer may be detected by various imaging techniques, but the presence is confirmed by cystoscopy and biopsy. Intravenous urography is used for in which there is ureter obstruction and hydronephrosis. CT scan and MRI are used to see the outgrowth of the tumor outside the bladder wall into surrounding viscera like prostate or uterus. MRI is preferred because MRI is more good for soft tissue structures. Chest X-ray and radionuclide bone scan is important in invasive bladder carcinoma as it may metastasize to lung or bone and then lung complete PET scan. The most common laboratory abnormality is hematuria, and in living cytology, examination of body stream of bladder portions for exfoliated cancer cells at high sensitivity and high grade. Diagnosis of initial staging of bladder cancer is made by cystoscopy and transureter resection. Superficial low-grade tumors usually appear as single or multiple papillary lesions. Use of fluorescent cystoscopy with blue light can enhance the ability to detect lesion by as much as 20%. The goal of URG is to enable histopathological diagnosis staging, which requires the inclusion of bladder muscle in the resection specimen. Prognostic markers. Prognostic markers are histopathological clinical markers. The most important is the pathological prognostic variable after radical cystectomy and lymph node dissection are tumor stage and lymph node status. Tumor diffusion has been associated with prognosis. Tumor located at the bladder neck or triangle of the bladder appears to have increased likelihood of nodal metastasis and has been associated with decreased survival. Prostatic ureter involvement at the time of radical cystectomy was also found to be associated with worse survival outcomes. Now we'll move towards management. Management, there is neoadjuvant therapy, surgical management, chemotherapy, and radiotherapy. In neoadjuvant therapy, chemotherapy can be given before planned radical cystectomy, neoadjuvant. And any attempt to decrease recurrence rate and in selected cases allow for bladder preservation. Approximately 20 to 43% of patients achieve a complete response to chemotherapy. However, additional treatment is still indicated because a substantial number of patients who believe to be free of tumor after chemotherapy alone are found to have infiltrating disease at the time of surgery. Neoadjuvant chemotherapy followed by surgery improves duration of survival when compared to surgery alone for patients with invasive disease. Patients who undergo neoadjuvant chemotherapy Early cystectomy is offered to those who do not tolerate chemotherapy, radiation, or both owing to toxicity, and those whose cancer fails to respond to such therapy. Complete response rate of chemoradiation may be as high as 50 to 70% initially, with 5-year overall survival rate approaching 50 to 60%. Systemic adjuvant chemotherapy for locally invasive but not metastatic bladder cancer should not yet be considered standard therapy. The general benefits of adjuvant chemotherapy include chemotherapy is administered after acute pathological staging. Therefore, treatment indication at low risk for micrometastasis is avoided, and no delay in definite surgical treatment. The drawback of adjuvant chemotherapy are assessment of in vivo chemosensitivity of the tumor as multiple problems. Delay or intolerability of chemotherapy due to post-operative problems are the drawbacks of the adjuvant chemotherapy. Then we move to surgery.
If we just stop here, you go back to the slide on neoadjuvant chemotherapy, where the title was written. Yes. You see, this whole concept of whether chemotherapy should be given prior to surgery or not, or whether surgery should be followed by chemotherapy, which is known as adjuvant chemotherapy. Now, this was a debate probably 10 years or 15 years back, and most of the urologists at that time were not of the opinion that neoadjuvant chemotherapy is something of any benefit. Rather, they would say that it delays the therapeutic window or delays the point in time in which the patient can have benefit from surgery. For instance, if you happen to see a patient with muscle invasive bladder cancer today, and you do a lot of investigations, for instance, CT scan and biochemistry and hematology, and you are about to do something called radical cystectomy. But if you don't do radical cystectomy now, and if you ask your colleague from the medical oncology team that you start something in the neoadjuvant setting, then those first 3 or 4 cycles of neoadjuvant chemotherapy would actually take away like maybe 3 months. And those 3 months are very crucial according to the thinking at that time, 15 years back. And that crucial time is because every surgeon wants to do surgery at a point when the results are better, the post-operative results are better, and the patient is in relatively good health to recover from the brunt of anesthesia and the brunt of something which is urinary diversion, which is a part and parcel of radical cystectomy. So there are a lot of things which were there in the minds of those people. But now the point has been proven. The point has been proven by results and randomized controlled trials. And now the people are of the opinion that if you start neoadjuvant chemotherapy, then this has got a benefit. Benefit in many ways, but one of the ways is it has got downgrading of the tumor. Now, what this downgrading means is, perhaps in some of the cases, when you do cystectomy after neoadjuvant chemotherapy, you won't find any tumor at all. Now, this is something of, say, a good news. But sometimes what it does is it makes some confusions. For instance, if you have done chemotherapy, neoadjuvant chemotherapy, and you have done radical cystectomy. Now, after radical cystectomy, you call your patient in the clinic and you want to just relate to him or just narrate to him the report comes through histopathology. And you say that in the bladder which I have taken out, there was no tumor present. So the patient can ask you, why in the first place you have operated on me? Because there was no tumor. So if there was no tumor and my tumor was sensitive to chemotherapy in the initial setting, so chemotherapy alone was enough. Why you have just taken out my tumor or my bladder? Because there was no tumor. But the answer to this question was or is that this is something which is called nipping in the bud. If you don't take out the bladder after the bladder has responded to chemotherapy, the nidus will always be there. The soil is there in which the fertility composition of the soil for the tumor to occur will be more as compared to at any time in life, because this is something, an organ which has been the seat of origin of the tumor. So in order to eradicate totally from the scene, from the health status of the patient, it was necessary to do away with the bladder. So this was the kind of argument that has to be done today, as was done in the past also. So this has to be very clear in mind that now every patient should be offered this standard protocol of neoadjuvant chemotherapy, which is prior to surgery. But there are certain people who want to have surgery first. There are certain people who do not want to go through chemotherapy because of various side effects of chemotherapy. But there are again certain people who want to get away with surgery, not because of the effects of chemotherapy, but rather psychologically speaking, they want to get rid of the tumor as quickly as possible. So again, there are certain people also in which you can't just do chemotherapy because of the status of GFR and other comorbid conditions present in the patient, because these are the patients who probably are in the 5th and 6th decade of their life. So this is a very interesting, and at one time it was debatable sort of a thing, but now it is not. Everything is now clear because of the evidence that we have. But again, the mind of the surgeon and the clinician or the medical oncologist, because both of them are working along with radiation oncologist, this makes the team which is known as MDT, multidisciplinary team. And every cancer, whether it's a bladder cancer or prostate cancer, every decision which pertains to cancer therapy, whether it is surgical or medical or radiation, it has to be done in consultation with all three of them. So now we are all on the same page, and this is something which is now a standard practice. We have to follow neoadjuvant followed by chemotherapy. Maybe we have to add adjuvant therapy, and the results are better now. Yes, please.
So I have a question here. Yes. If once the bladder is free of tumor on its surface, so will you do radical cystectomy or will you do simple cystectomy?
No, it should be radical. It should be radical because simple cystectomy won't serve the purpose. The purpose is not only to take out the organ, but also to take out those lymph nodes which actually are draining the neoplastic cells. If this neoplastic cellular effluent is not taken into consideration, then you won't be in a position to plan for the template for radiation, for instance. So you have to have the knowledge of what is the lymph node status, because that comes then that has got its value in the decision made by medical oncologist and by radiation oncologist to do something in addition to surgery. Right, please proceed.
Okay, now we'll start with surgical management. Radical cystectomy is the gold standard surgical option for muscular invasive bladder carcinoma. Radical cystectomy implies removal of anterior pelvic organ in man's bladder with a In women, the bladder, the surrounding fat, peritoneal attachment, and cervix, uterus, anterior vaginal wall, urethra, and ovaries. In pre-menopausal women, if the tumor is not that invasive, we can spare vaginal bed, wall, and uterus. Sparing of urethra allows for construction of new bladder that can be anastomosed for urethral vein management. Disease survival for 5 years after surgery based on tumor stage is if the patient is in stage tumor T2 stage, it is 81%. If it is in T3A, it is 68, and if it is in T3B, it's 47%, and 44% in 4A stage. Recurrence after surgery usually occurs within the first 3 years. Local pelvic recurrence rates are low, 7 to 10%. Most patients with therapy have distant disease recurrence. The risk of urethral tumor occurrence or recurrence in man who undergoes radical cystectomy is between 6.1 to 10.6%. Risk factor for urethral tumor involved in man includes infiltration of prostatic stroma or prostatic urethra with cancer or cancer inside. Patients with these risk factors are candidate for urethrectomy either at the time of radical cystectomy or as a separate procedure. Radical cystectomy in 4 main types of sexual preserving techniques has been described. The first one is prostate-sparing cystectomy, in which the part of or the whole prostate is preserved, including a seminal vesicle, vas deferens, and neurovascular bundle. Second is capsule-sparing cystectomy, in which the capsule or the peripheral part of the prostate is preserved with the adenoma, including the prostatic urethra, removed by PROD. Seminal vesicles, vas deferens, and neurovascular bundles are also preserved. The third is seminal sparing cystectomy, in which seminal vesicles, vas deferens, and neurovascular bundles are preserved. The fourth one is nerve sparing cystectomy, in which the neurovascular bundles are the only tissue left in place. But this is only given to patients who need sexual preserving technique. This is not recommended in all of the patients who are doing radical cystectomy. In women with bladder cancer who have uninvolved urethral margins at the time of cystectomy and whose tumor was not located at the bladder neck are candidates for bladder replacement. Approximately 66% of women undergoing radical cystectomy for the management of bladder cancer fall into this group. In such women, even the uterus substantial portion of the vaginal wall, fallopian tube, and ovaries can be spared. Bilateral lymph node dissection is usually performed simultaneously with radical cystectomy. Lymph node metastases are amplified in approximately 20 to 35% of patients. Patients with lymph node metastases have poor prognosis. Patients with fewer than 5 positive nodes and organ-confined disease in the family tumor tends to have a better prognosis than patients with more extensive disease. These patients may also benefit from adjuvant chemotherapy. Unit evaluation after radical cystectomy, there are 3 alternatives which are currently used after cystectomy. One is the abdominal diversion, such as ureterocuterostomy, period or chronic convoy. Urethral diversion, which includes various forms of gastrointestinal pouches attached to the urethra as a continent, orthotopic urinary diversion, new bladder, orthotopic bladder, substitution. And the third is rectosigmoid diversion, such as uretero-ureorectostomy. And this picture you can see the conventional ureteroconvoy. The surgeon transplants the ureter to the isolated section of the terminal ileum, ureteroconvoy, bringing one end of the abdominal wall to the abdominal wall. The ureter may also be transplanted into the transverse sigmoid colon convoy or proximal jejunum convoy. And the second picture is the cutaneous ureterostomy. The surgeon brings the detached ureter to the abdominal wall and attaches it to the opening in the skin.
So if just stop for a moment here, all those points that you have described in the previous 2-3 slides regarding the sparing of organs which are involved in sexual activity. For somebody who is in the business of cystectomy and caring for patients who are having muscle invasive bladder tumor, I think these all 4 types of sparing surgeries are not on. Why they are not on? By on I mean they can't be accepted, just because of the reason that what we want to have when we do surgery known as oncological surgery, we want to have less of the cosmesis or the sparing effect, rather than to have something called clearance of the cancer. So cancer clearance is more important as compared to any other aspect. So if you want to preserve something, but you want to compromise on the aspect of cancer clearance, then again, this is not something which is expected of radical surgery. What we expect from radical surgery is total clearance of all those tissues which are involved or which might involve in very near future. Might involve means whenever I take out the bladder, I also take out all the perivesical tissue along with it. I want to clear all the lymph nodes up to the level of, for instance, maybe bifurcation of aorta and IVC. Why I want to do it? Just because of the reason that all these lymph nodes at one point will give you the burden of disease that has already been present. Second, when they are cleared, the space will give you a kind of a template on which you have to combine something called something called radiation. This is all done in order to have a complete clearance of the disease, oncological disease. It is not something to preserve. So whenever somebody does it, for instance, a prostate sparing cystectomy or capsule sparing cystectomy, yes, we do. I always have this question to my colleagues also, that what you have to achieve is something which is not needed. What you have achieved in prostate sparing cystectomy is something which is the intact availability of external sphincter. So if you are planning to do, for instance, orthotopic bladder substitution, yes, you need that kind of interface so that the external sphincter muscles should act and the patient becomes continent. But if you leave behind prostate, you are actually leaving behind prostatic urethra. You are leaving behind prostatic urethra because this part of the urethra is also having the same kind of epithelium as the bladder. So you're leaving behind the nidus, which might be having the unstable picture of turning into malignant tissue. So you are compromising too much. You are gaining nothing. So if you go back to the picture, the third one, this one, you see, if you take out the whole thing, which means bladder, urethra, and prostate, so this becomes cystoprostectomy, and this is the complete clearance along with the lymph nodes. If you don't do it in a male gender, if you leave behind something, as I have said, you are leaving behind a lot. But if you take out this thing, and if you have already done your homework, there is no involvement of prostatic urethra or the bladder neck with the, by involvement I mean the presence of bladder tumor on CT scan and cystoscopy and random biopsies, then and only then you can plan something called orthotopic bladder substitution. Otherwise, you do the same thing, and what you do, you make use of a segment of small intestine, the ileum, and make an ileal conduit. Or otherwise, if the patient has got probably compromise in renal function, probably a lower GFR, probably a patient who cannot withstand the brunt of surgery, long duration of surgery. What you do is you disconnect the ureters, and you disconnect the ureters from the bladder. You take out the ureters through the skin, either through separate holes or through the umbilicus. We can take both the ureters through the umbilicus, and this is known as cutaneous ureterostomy. And by that, you are actually leaving behind the bladder, which can then in future be a candidate for radiotherapy. So you are containing the disease rather than removing the disease. So our planning should be to remove the disease as much as possible. But if that is not possible, then you can just do some containment rather than you want to preserve something which might not be needed at the age of, say, 60 or 65 years. But that is something which is debatable again. But there are certain things which are very clear, which we all have to learn, which we all have to practice. Otherwise, we'll be practicing something called compromisation. Yes, please.
This one, bladder sparing treatment for localized disease. Transurethral resection of bladder tumor alone in patient with muscle invasive bladder tumor is only possible as the bureaucratic conflict with the tumor growth is limited to superficial muscle layer, and its restaging biopsies are negative for virtual invasive chemotherapy. Approximately 15% of patients who present with bladder cancer are found to have regional or distant metastasis. 30 to 40% of patients with invasive disease develop distant metastasis despite medical mastectomy or their radiotherapy. Early results with single chemotherapy agent and subsequent combination of drug have shown that significant number of patients with metastatic bladder cancer respond partially or completely. Cisplatin is the most active agent which can use alone reduce responses in approximately 30% of the patients. Other effective agents include methotrexate, doxorubicin, vinblastine, cyclophosphamide, gemcitabine, and 5-fluorouracil. Leveraging of methotrexate, vinblastine, doxorubicin, and cisplatin and black have been the most commonly used for patients with advanced bladder cancer. Approximately 13 to 35% of patients receiving such agents attain complete response. Median survival time is approximately 1 year, and sustained survival rate is 20 to 25%. The treatment with and that is associated with substantial toxicity, including toxic death rate of 3 to 4%. The newer agent is ifosfamide, gemcitabine, lexatil, and gallium nitrate. A study demonstrated similar overall survival time with treatment failure and response rate for patients treated with NSAID and those treated with a combination of gemcitabine and cisplatin. The advantage of gemcitabine and cisplatin over NSAID is significantly lower toxicity and improved tolerability.
There is another protocol, and that is this is MVAC, and that is CMV. Now CMV is cisplatin, methotrexate, and vinblastine. So we have got historically CMV, MVAC, and now gemcitabine and cisplatin. So what do we have in SIUT these days is gemcitabine and cisplatin. So it is something of interest to those who want to work in this field, that with the passage of time we have got more improved say index of response from the combination of drugs that we use now. So now the drugs have those who have got less side effect and more of complete responses on a percentage level. Yes, please.
Radiotherapy. External beam irradiation delivered infection over a 5 to 8 years is an alternative to radical cystectomy in well-selected patients with deeply infiltrating bladder cancer. Treatment is tumor recurrence is common, occurring in approximately 33 to 68% of the patient. Possibly radiation as a monotherapy is usually offered to those patients who are surgical candidates due to advanced age or secondary comorbid medical problems. That's why radiotherapy has no such role like definite treatment of the muscle invasive bladder carcinoma. This is the flow chart of like during diagnosis with cystoscopy and UNRESECTABLETUMOURS, evaluation of urethra, CT, imaging for abdomen, chest, and upper urinary tract. MRI can be used for local staging. If the findings are between stage 2 to 4 with no nodes and metastasis, we go for neoadjuvant. We go for neoadjuvant therapy. With this pattern, this patient has 5 to 8% survival benefit. In this patient, radiotherapy is not recommended, and immunotherapy is still under clinical process. Then we go for vertical cystectomy. We can tell the patient surgical technique is like integrated nodal dissection, divestment planning will be important. And in higher case, very improved outcome. And then adjuvant therapy, chemotherapy can be given in high risk patient. Only a more adjuvant therapy was given. The unresectable tumor, palliative cystectomy of muscle invasive bladder carcinoma. Locally advanced tumor, T4D, invading pelvic or abdominal wall, may be accompanied by several debilitating symptoms, including bleeding, pain, dysuria, and urinary obstruction. These patients are candidates of palliative treatment such as palliative radiotherapy. Palliative cystectomy with urinary diversion carries the greatest morbidity and should be considered for symptom relief only if there are no other options. Now we come towards the follow-up. Appropriate schedule for disease monitoring should be based on natural timing of recurrence, probability, and size of recurrence, and functional monitoring after urinary diversion and potential available management. Local recurrence takes place in the soft tissue of the original surgical site or in the fluid. Complex cystectomy has a 5 to 15% probability of pelvic recurrence, which usually occurs in the first 24 months. Most often within 6 to 18 months after surgery. Late recurrence can occur up to 5 years after radical cystectomy. Risk factor described as pathological stage, lymph node polyposis, extent of lymph node dissection, and perioperative chemotherapy. Patient usually has poor prognosis after pelvic recurrence. Definite therapy can prolong survival, but mostly provide significant radiation of symptoms. Multimodality management generally involves combination of chemo, radiation, and surgery. Distal recurrence is seen up to 50% of patients treated with radical cystectomy for muscle invasive bladder carcinoma. Systemic recurrence is more common in local advanced disease, stage 3-4, ranging from 32 to 62%, and in patients with lymph node involvement ranging from 52 to 70%. Most likely site of distant recurrence are lymph nodes, lung, liver, and bone. Nearly 90% of distant recurrence appears within the first 3 years of radical cystectomy, mainly in the first 2 years, although late recurrence has been described after more than 10 years. Patient with progressive disease treated with platinum-based chemotherapy and median survival is 9 to 26 months. Urethral recurrence after radical cystectomy, incidence of new urethral tumor was 4.4%. Risk factors of secondary urethral tumors are urethral malignancy and prostatic urethra, prostate, and lateral orthotopic pneumobladder associated with a significant low risk of urethral tumors after radical cystectomy. Upper urinary tract and lung cancer occur in 4 to 10% of cases and represent the most common site of late recurrence. Follow-up schedule has been suggested, guided by the principle that recurrence tends to occur within the first year following initial treatment, as suggested by EEU guidelines that include CT scan every 6 months until 3rd year, followed by annual imaging thereafter. Patient with multifocal disease, non-muscle invasive bladder carcinoma with cancer in situ, or positive real margin are in higher risk of developing upper urinary tract carcinoma, which can develop provide exact time to stop or is not very good. Thank you.
Thank you. Good. Very good. So just to recap what has been discussed today. First of all, we have to imagine that this whole urological disease starts from the kidney. You see, this is the same epithelium which is found in the renal pelvis. Then it lines the ureter, then it lines the bladder, and then the prostatic part of the urethra. Now, this common transitional cell epithelium is the seat of transitional cell carcinoma, the most common carcinoma of the bladder. So what we have discussed today is transitional cell carcinoma in the muscle invasive setting, which is like PT2 and beyond. Whenever one wants to focus, then one also has to take this thing into consideration, that there is an anatomical continuity. Now, whenever you want to focus on the bladder, because the person comes to you with hematuria and you have done your investigative workup, and you have found that there is a right lateral wall or the left lateral wall bladder tumor, then you must not forget that this is again in continuity in the upper tract and as well as going down into the urethra. Now, if you are of this kind of imagination, then you will be actually doing something for the bladder and for this patient, and also plan your follow-up protocol, because you will always be in search of something in these two areas, upper tract and the tract which has been left behind. For instance, if you have planned some surgery like radical cystectomy, or which is cystoprostectomy, you have taken out the bladder, but you have left behind the ureters. You have taken down the prostatic part of the urethra plus the prostate, but you have left behind the urethra which is beyond the prostate. Perhaps you have done orthotopic bladder substitution, or a new bladder, or something called ileal conduit, or the fourth thing, which is cutaneous ureterostomy. But since this epithelium is a continuous sheath of transitional cell epithelium, then any part can be turned into malignant form in later life. For instance, if we take into consideration the part of the urethra which has been left behind beyond prostatic urethra, now this has some kind of association. Maybe in future patient can give you a history that there is still some trickling of blood. Now, if that trickling of blood is because of the epithelium turning into malignancy, then you have to take out this part of urethra also. First, you have to image that part, and that can be done through two things. You cannot do urethroscopy because the upper end of urethra is either closed or it is taken on by the new tissue, which is a new bladder. So that depends upon the situation in which you have done the urinary diversion. So urethroscopy is sometimes, or in most of the times, contraindicated. What you can do is to get help from some imaging technique, and the most promising imaging technique is MRI of the urethra. Now, you can do CT scan, but if you compare head to head between CT scan and MRI, MRI has got more resolution for urethra as compared to CT scan. So once you have pinpointed that there is a seat of some abnormal tissue in the urethra, then you have to plan something called urethrectomy, and then you take out the whole urethra right up to the glans penis. So that is the kind of follow-up, an active or a proactive follow-up that you always do. For instance, I'm talking about the lower tract. If you think about the upper tract, the two ureters and the two kidneys which you have left behind, they can also turn into malignancy sometimes in later life. So you have to look for them also in future when you follow these patients. So you don't have to just focus on the bladder in future. You have to focus up and down the bladder. So that is my point. The second thing is, whenever you want to do something called radical cystectomy, first you have to think about neoadjuvant chemotherapy, but that is the job of your colleague from the medical oncology side. But you also have to think about some newer adjustments. For instance, the lifestyle adjustment of urinary diversion. So you have to talk to your patient and talk to the relatives of the patient and those who live with him or with her, that how they are going to tackle this problem. No treatment or no procedure of urinary diversion is acceptable to everybody. Every person has got um, his or her own preoccupations, say some questions about adjusting to a newer way of life in which this diverted urine is to be collected. For instance, if you provide an ileal conduit, then the person has to think about wearing a urostomy bag day in and day out. So how they are going to lie down, how they are going to stand up, what is the position, how they are going to handle whenever something happens to the bag and the bag slips out. So all this have to be taken into consideration by the surgeon who wants to do or who wants to practice this procedure. If you want to do something called orthotopic bladder substitution, then you must be pretty sure about the sphincteric activity of that patient. The bladder which you are providing not only has to store, but also the person has to be continent. There should not be any leakage. And then you ask the patient not to do urination in a squatting position, because then the whole new bladder will not be able to function properly. Then you ask the patient to put himself or herself on a commode, on a seated position, so that there is less amount of pressure, and the body posture should not be that you do some squeezing of the bladder down the umbilicus. So there are a lot of adjustments that has to be done. Similarly, if you are providing orthotopic, or you are providing a new bladder, for instance, an Indiana pouch with a Metrofenoff channel, you can do it. But mind you, if you are thinking about radiotherapy, then you can't do orthotopic and you can't do a new bladder, because that is in the way of your radiation template. If you want to do radiation after ileal conduit, then you have to ask your radiation oncologist that first they have to do a leukogram to see how much is the descent of the loop into the pelvis, because that should not be in the way of the radiotherapy. If it is in the way of radiotherapy, then your anastomotic lines will be disrupted by the radiation, which you don't want to do. So there are many things that have to be considered. It's not simple radical cystectomy. It is a very, very complex procedure, not only in terms of doing it, but also in terms of asking your patient to adjust to a newer way of life. So that needs a lot of thinking and discussion. So that is my take on the subject and a brief review. So if anybody wants to ask anything, and the forum is open. So there is no question. So are you there or you are not?
Yes, sir, we are here.
All right.
Sir, the GI tract is मतलब उनका जो artically में it's very absorptive. So whenever we put a conduit, so when we observe the side effects of absorption in the blood, the urea, the excretory material that's being absorbed by the area.
Yes, certainly. And that is the reason why we always try to calculate GFR, eGFR beforehand. So if eGFR is less than, say, perhaps 65, then your patient will be having a lot of problems in future, because whether you use ileum for ileal conduit or you use ileum for new bladder formation, orthotopic bladder. Uh, Ileum is an absorptive surface. The more you provide, for instance, the longer the segment, the more will be the surface area for absorption. So the longer the segment for ileal conduit, or the longer the segment for um, uh, uh, dividing at the antimesenteric border, making a plate of it, and then fashioning it in the form of a vesicle, that surface, internal surface, is an absorptive surface. And since the act of micturition is not like what it was earlier, urine has to be in contact with this absorptive surface more as compared to a normal bladder, which is a non-absorptive surface. So here, if urea and creatinine are of a, say, higher level, then that will be again reabsorbed into the circulation and goes towards the kidneys to just get rid them of. So it's a kind of a cycle which goes on, and the person, if you start with GFR at 65, for instance, if you take the GFR after 6 months of time or maybe 1 year of time, you will always see that these people who have gone through radical cystectomy and urinary diversion, they have got a decrease in GFR. So this decrease in GFR, which again reflects on the morbidity index, will always be something to be taken care of. So anybody who has to go through this kind of surgery has to be checked for eGFR, not only before surgery but also after surgery. The second thing is, for instance, if your patient is having a bladder disease plus the person is having say CKD 2 or 3 status, then this patient should be offered either ileal conduit or perhaps only cutaneous ureterostomy, because cutaneous ureterostomy is the only way of providing an outlet without any absorptive surface, because then the ureters are just on the edge of the skin and there is no absorptive epithelium in front of it. So that is something which you can do just to minimize morbidity in such patients. So it was nice talking to you, not only today, but also for the past 14 days. And if you want to ask me my impression is that I'm surprised. I'm surprised not only from the angle of not expecting such kind of participation and commitment from yourself, because and also not expecting something from such a far off distance as you are. You are not in front of at least me. So whenever somebody is in front of the person whom you are speaking to, then there are many things that can be conveyed otherwise. So it was difficult from your angle also to just convey what you want to convey. And I think on that point you have scored marvelously. The second thing is your presentation skills. I can say for all of them, there were some brilliant expressions, some not so brilliant expressions, but everybody has expressed himself properly. The material that you have gone through, I think there is always room for improvement, and this is the way we learn. This is the way we understand things. Perhaps in the second round, we'll be able to learn more. I will try my best to engage you as much as possible. For me, for these 14 different aspects of urology, if they are studied properly, then they can be a help for your future direction also in terms of research. It is not necessary that what I have given just randomly will be your part of research. It can be or it cannot be. It depends upon your own inclination. And again, we'll be having supervisors separately for you. So it depends upon your supervisor and your understanding. It's a two-way communication, but at least the process has started, and the process has to be started somewhere. So this was the kind of modus operandi for your previous batch, two batches also, and for you, we have done the same thing. This is my take on this activity. If you have got any suggestions, any reflections, I'm more than welcome to listen to you. You want to say something? No? Okay. So perhaps from there'll be a lecture by presentation by Noman on Saturday, and then we will do the second round presentations from Monday onwards, right? And I have included your telephone numbers and your contacts on the SIUT PG online WhatsApp group also. So you can also participate in our online activities. We have got 3 activities: one on Monday, one on Wednesday, and the third one on Friday. So you can all participate in it. Every presentation every day is followed by an online test, and that test again can be submitted online, and it is posted for only 12 hours. You can follow all those messages on our group, and then you can understand. If there is any doubt, you can contact me personally. Right? Okay. Right. Thank you. Dafis.